Hello everyone, we are Group 3, so our topic for today is all about ectopic pregnancy.
Presenting our group members to start with Ms. Haravata Juliana Mariel, Mr. Ledda Denver John, Ms. Labsan Kathleen Kate, Ms. Mendoza Fabigail, yours truly, and lastly, Ms. Parong Bianca Angela.
First, it's include its definition. Second, its types of the ectopic pregnancy. Third, its clinical manifestation. Fourth is the diagnostic findings. Fifth is the medical management. Sixth is the pharmacologic therapy. And last but not the least is the nursing management. Without further ado, let's start with the definition and the types of ectopic pregnancy.
So what is an ectopic pregnancy? So an ectopic pregnancy is a type of pregnancy that happens outside your uterus. This occurs when a fertilized egg implants in a location where it cannot support a growth. So an ectopic pregnancy most often happens in your fallopian tube. Pregnancies can continue if they're ectopic because only your uterus is meant to carry a pregnancy. This abnormal implantation prevents the embryo from growing properly and can be a serious health risk if not treated. So an ectopic pregnancies can become a life-threatening, especially if your fallopian tube breaks or ruptures. This can result to a ruptured ectopic pregnancy, and it can cause severe bleeding, infection, and sometimes death. This can become a medical emergency, and it requires medical attention to treat or quickly and to avoid further complications. And then we also have the types of an ectopic pregnancy. First is the tubal ectopic pregnancy. This is the frequent type, where the fertilized egg implants in one of the fallopian tubes instead of the uterus. So this happens in the tubal part wherein the fallopian tube. And then we also have the non-tubal ectopic pregnancies. This can happen in areas such as cervix, ovary, abdominal cavity, cesarean scar, uterine carnoa, and within the broad ligament. We also have the ovarian ectopic pregnancy, when the egg implants in the ovary. So this happens when the fertilized egg implants in the ovary and it grows until it becomes a fetus. And then we also have the cervical ectopic pregnancy, when the embryo attaches to the cervix, the narrow lower part of the uterus. We also have the abdominal ectopic pregnancy, when the embryo implants in the abdominal cavity outside reproductive organs. And then we also have the intertestanial or the corneal ectopic pregnancy. This occurs when the embryo implants in the part of the fallopian tube where it meets the uterus. It poses a higher risk of rupture or severe bleeding. And lastly, we also have the heterotopic pregnancy. In rare instances, a woman may experience both an ectopic pregnancy and a normal intrauterine pregnancy at the same time. This condition requires careful management to ensure both pregnancies are safely monitored.
Next, let's dive into its clinical manifestations of ectopic pregnancy. First is the abdominal pain. The abdominal pain is one of the earliest and most common symptoms, usually localized to one side of the lower abdomen where the ectopic pregnancy is located. The pain can be sharp, crampy, or constant and may be worsened with movement or bowel movements. As the condition progresses, the pain may become severe, especially if the fallopian tube is stretched or abdominal pain is ruptured. Abdominal pain is a hallmark symptom of ectopic pregnancy because the fallopian tube is not designed to accommodate a growing embryo. As the pregnancy develops, it stretches the thin-walled tube, leading to localized pain. Additionally, the trophoblastic invasion can cause irritation and inflammation, further exacerbating the discomfort. In cases where the tube ruptures, internal bleeding occurs, leading to severe sharp pain that may radiate to the shoulder due to the diaphragmatic irritation from blood into the peritoneal cavity. The degree of pain varies depending on whether the tube is merely distended or has already ruptured, but in both cases, it remains a key warning sign of an ectopic pregnancy. Next is the amenorrhea, or what we call the missed period. Occurs because the fertilized egg has implanted outside the uterus, preventing normal pregnancy development. Many patients may assume they are pregnant until other symptoms such as pain and bleeding appear. However, some women may experience irregular spotting instead of completely missing their period. occurs because the fertilized egg still initiates pregnancy like hormonal changes despite its improper implantation site. The trophoblast cells continue to produce human chorionic gonadotropin, or what we call the HCG, which prevents the breakdown of the corpus luteum, thus sustaining progesterone levels and halting the menstrual cycle. This leads the patient to believe she is experiencing a normal pregnancy when, in reality, the embryo is growing in an unsuitable environment. The absence of proper implantation in the uterus eventually disrupts hormonal balance, leading to a breakdown in the pregnancy's support system, which may contribute to further complications such as the abdominal bleeding and an eventual pregnancy failure. Lastly is the vaginal bleeding. Vaginal bleeding can range from light spotting to heavy bleeding and is often mistaken for a normal menstrual period. This bleeding is usually darker than a regular period and it may be intermittent. This occurs because the ectopic pregnancy cannot properly support the growing embryo, leading to the shedding of the uterine lining. Vaginal bleeding in ectopic pregnancy results from instability of the implantation site and the body's attempt to shed the decidualized endometrium, unlike a normal pregnancy in which the embryo securely implants into the thick, vascularized uterine lining. An ectopic pregnancy implants in a location that cannot sustain it. The growing embryo may erode nervy blood vessels, leading to light or the heavy bleeding. Additionally, without proper implantation, the uterine lining is not adequately maintained, causing portion of it to shed and appear as irregular spotting. In more severe cases, the bleeding may be due to the rupture, leading to internal hemorrhage and hypovolemic shock, which requires the medical management.
So let's proceed to the diagnostic findings. First is the serum beta HCG test, a blood that measures levels of human chorionic gonadotropin, HCG, a hormone produced during pregnancy. In a normal pregnancy, HCG levels double every 48 hours in early gestation. But in ectopic pregnancy, HCG levels are often lower than expected or rise more slowly, indicating abnormal implantation. Example, if a pregnant woman HCG levels is 1,500 international units per liter, after 2 days, her HCG levels check again but only rises for 1,700 international units per liter instead of doubling. This slow increase suggests ectopic pregnancy. Second is transvaginal ultrasound. It is a high-frequency ultrasound probe inserted into a vagina to get a detailed view of reproductive organs. A normal intrauterine pregnancy should be visible on ultrasound by 5 to 6 weeks of gestation. If the ultrasound fails to detect a gestational sac in the uterus but HCG is elevated, ectopic pregnancy is suspected. For example, if a pregnant woman goes for ultrasound at 6 weeks but no baby is seen inside the uterus, instead, the ultrasound shows a small mass in her right fallopian tube, this strongly suggests an ectopic pregnancy. Third is the kulducentesis. It is a procedure in which a needle is inserted through the vaginal wall to check for free blood in the peritoneal cavity. Positive result or the presence of non-clotting blood suggests internal bleeding due to the availability of ultrasound. Kulducentesis can help confirm the hemoperitoneum or the blood in the abdominal cavity. Example, if a pregnant woman arrives at the emergency with severe abdominal pain, her doctor will perform a kulducentesis and withdraws a dark, non-clotting blood, confirming that she has an internal bleeding from a ruptured ectopic pregnancy. And she is immediately prepared for an emergency surgery. And lastly is the complete blood count. A blood test measures different components of blood, including red blood cells, white blood cells, and platelets. Low hemoglobin and hematocrit indicate blood loss, suggesting a rupture and internal bleeding. Increased white blood cell count may signal infection or inflammation. For example, if a woman with an ectopic pregnancy is found to have a hemoglobin level of 8 grams per deciliter, while the normal is 12 to 16 grams per deciliter, it means she has a lot of significant amount of blood and may need a blood transfusion.
Medical management of ectopic pregnancy is an effective treatment option for patients who are stable and have low HCG levels, typically below 3,000 liters, without signs of fetal viability. The primary medication used is methotrexate, which is administered via injection. This drug works by inhibiting cell division, effectively terminating the ectopic. Before treatment, it is essential to ensure that the patient does not have any contraindications, such as liver issues or significant blood disorders, and that the ectopic mass is not too large or showing signs of cardiac activity. After receiving methotrexate, patients are monitored through blood tests to track HCG levels, which should decrease over time. If the levels do not drop sufficiently, a second dose may be necessary. It is important to recognize that the medical management of ectopic pregnancy is a critical option for patients who meet specific criteria. This approach not only helps in effectively terminating the ectopic pregnancy, but also preserves the patient's reproductive health for the future. Ongoing monitoring and patient education are vital components of this treatment to ensure safety and success.
These slides cover the pharmacological therapy of ectopic pregnancy, focusing on mifepristone. This medication inhibits progesterone, leading to shrinkage of corpus luteum and the breakdown of pregnancy-supporting tissues. It is administered orally and is commonly prescribed for early, unruptured ectopic pregnancies, often in combination with misoprostol. However, its use is not recommended in case of ruptured ectopic pregnancy, adrenal insufficiency, severe anemia, or uncontrolled asthma. Potential side effects including vaginal bleeding, abdominal cramps, nausea, headache, and fatigue. Close medical supervision and follow-up are essential to ensure the pregnancy is fully terminated. There's a methotrexate provides a non-surgical alternative for managing ectopic pregnancy, minimizing surgical risk. However, it requires strict patient selection and continuous monitoring to ensure the effectiveness and safety. For the mechanism of action and administration, the route is administered through an intramuscular injection. Indication recommended for early unruptured ectopic pregnancy where the BHCG is below 5,000 in MIU, ML, and no fetal cardiac activity is present. For the contraindication, no suitable for ruptured ectopic pregnancy, liver or kidney diseases, anemia, breastfeeding, or immunocompromised patient. For the side effects, possible adverse effect include abdominal pain, nausea, vomiting, fatigue, oral ulcer, and liver toxicity. For the administration guidelines, patient must avoid alcohol, folic acid supplements, and strenuous activity. HCG levels should be monitored until they decrease to less than 5 MIU, ML, confirming the treatment successful. RH immunoglobulin is administered to RH-negative mothers to prevent RH sensation after events like ectopic pregnancy, miscarriage, abortion, or delivery. The route is intramuscular or IM or intravenous or IV injection. Indication given after ectopic pregnancy, miscarriage, abortion, or delivery to prevent maternal immune response. Contraindication are H-positive mothers or those already sensitized. Side effect, mild fever, soreness at injection sites, rare allergic reaction. Administration given within 72 hours of potential RS. Exposure to prevent future complication in pregnancy. These medications are crucial in managing ectopic pregnancy, either by stopping abnormal pregnancy growth, facilitating its termination, or prevent immune complication in future pregnancy.
So for the nursing management, first is to ensure that appropriate physical needs are addressed and monitor for complications. Assess the vital signs, bleeding, and pain. Second is the administration of methotrexate. So methotrexate is a chemotherapeutic agent that is folic acid antagonist. It destroys rapidly growing cells such as trophoblast and the zygote. So this would be administered until a negative HCG titer result have been produced. Last one is withdrawing of blood sample. A large amount of blood would be lost. So blood typing and cross-matching must be done in anticipation of a blood transfusion. In addition, the blood sample will be also used to determine the hemoglobin levels of the pregnant women.